Infection in renal transplant patient. The timeline of the infectious organism after kidney transplant from 0 to 1 month: nosocomial, pneumonia, UTI, bloodstream infections, wound infection, herpes virus, and oral candidiasis. From 1 to 6, cytomegalovirus, bilioma virus, pneumocystis jirovecii, cryptococcus, nocardia, toxoplasma, listeria, candida, aspergillus, and other fungal infections. And after 6 months of transplantation, community infections, cytomegalovirus, herpes virus, cryptococcus, bilioma virus, and mycobacterium. Prophylaxis use in transplant recipients are very important. Wound infections by perioperative antibiotics, urinary tract infection by triusupreme, sulfamethoxazole, and quinolones, herpes virus infection, acyclovir, varicella zoster infection, acyclovir, Epstein-Barr virus, acyclovir, valganciclovir, and ganciclovir, cytomegalovirus by ganciclovir and valganciclovir, pneumocystis jirovecii, trimusupreme, sulfamethoxazole, and oral candidiasis by giving nystatin drops. CMV risk prophylaxis and treatment. CMV risk categories are classified into high risk from CMV donor positive to recipient negative, intermediate risk from donor positive to recipient positive, and low risk from donor negative to recipient negative. Prophylaxis medications for CMV, now valganciclovir 900 mg oral daily. Treatment medications, ganciclovir intravenous 5 mg per kilogram every 12 hours, and the valganciclovir 900 mg oral twice daily, and for resistant cases, cidofovir, foscarnet, and leflunomide. There are many viral infections. Human herpes virus are of many types. Type 1 for herpes simplex virus, and type 2 genital herpes, varicella zoster type 3, Epstein-Barr virus type 4, cytomegalovirus type 5, and Kaposi sarcoma virus type 8. Bilioma virus, BK virus nephropathy, GC virus resulting in progressive multifocal leukoencephalopathy, human papilloma virus, squamous cell carcinoma of the skin, vulva, anus, and cervix, parvovirus B19 resulting in anemia, and tropical spastic paraplegia and T-cell leukemia lymphoma, and other viruses as adenovirus, hepatitis C, B, and HIV. Bacterial infections accounts for about 80% of all infections, and urinary tract infection is the most common infection occurring in renal transplant recipients. Poor outcome is associated with gram-negative bacteria and multi-resistant organism and candida species. Infection with Corium bacterium urealyticum is associated with incrustation and urinary tract obstruction and can be difficult to isolate with routine culture methods. Listeria monocytogenes, Legionella, Mycobacterium, tuberculosis, non-tuberculous mycobacteria, vancomycin-resistant enterococci, and methicillin-resistant Staph aureus are among problem bacteria which may present as pneumonia, meningitis, cellulitis, osteomyelitis, or generalized sepsis. Pneumocystis jirovecii infection usually occur in the first 6 months of transplantation, but may occasionally occur later, particularly during periods of increased immunosuppression. Cryptococcus pneumonians can cause pneumonia and meningoencephalitis. Other types of fungal infection may be less common in Egypt. Parasitic infection as strongyloids, which result in a state of risk of hyperinfection syndrome in patients from endemic region, and Toxoplasma gondii associated with CNS disease and chorioretinitis. This is a case of rhino-ocular cerebral mucormycosis resulting in a patient with over-immunosuppressed post-renal transplantation. An effective immune response against the viral infection depends on the activation of the cytotoxic T cells that can clear infection by killing virus-infected cells. Tacrolimus MMF prednisone inhibits the T cell mediated immune response, and transplant recipients are at higher risk for viral infections. Individually, I will discuss some of the most important viruses post-renal transplantation. Cytomegalovirus is a human herpes virus 5. Seroprevalence of CMV is around 60% in the general population. Transmission is through blood, sexual intercourse, and transplanted organs. Active infection in kidney transplant recipients is 30 to 70% without prophylaxis at 1 month from transplant, with the highest rate in patients with donor CMV IgG positive into recipient negative. CMV infection lead to increased morbidity, mortality, and allograft failure. The risk factors for CMV infection: highest risk from positive to negative recipient, neutropenia, comorbid illnesses, and lack of CMV prophylaxis. And CMV infection is uncommon in CMV negative into recipient negative and often considered as a disease of over-immunosuppression. Clinical presentation occur with, as mentioned before, from 1 to 2 months after prophylaxis course is completed. CMV viremia is defined as the presence of CMV replication in blood regardless of whether signs or symptoms are present. CMV disease, CMV syndrome, fever, malaise, arthralgia, leukopenia, thrombocytopenia with no tissue invasion, and tissue invasive CMV disease with end organ involvement as retinitis, enteritis, colitis, hepatitis, nephritis, encephalitis, or pneumonitis. And of course, diagnosis is by PCR for detection of CMV DNA. Prophylaxis, as mentioned, is given for 3 to 9 months based on the donor and recipient serostatus. Valganciclovir is usually used for prophylaxis for medium to high risk transmission, and standard dose is 900 milligram daily for 3 to 9 months. And those should be, of course, reduced according to estimated GFR. For GFR from 30 to 60, the dose should be 450 milligram daily. And for low risk of transmission CMV negative into CMV negative recipient, acyclovir can be tried for 200 milligram twice a day for 3 months. For treatment of viral infections after renal transplantation, in mild to moderate viral infection, MMF withdrawal, tacrolimus reduction, and continuation of prednisolone. And for moderate to severe viral infection, MMF withdrawal, tacrolimus withdrawal, and continuation of prednisolone. Treatment of CMV infection include decreasing immunosuppression and 2 main strategies: decrease antimetabolites by 50% with maintenance of CNI, or hold the antimetabolite and continue current dose of CNI. At Washington University, for level CMV viremia or patient with high risk of rejection, they restart 50% of the previous dose of antimetabolites 3 months after resolution of CMV viremia. In addition to titrating down the immunosuppression, start antiviral therapy, and for mild CMV disease, treat with oral therapy of valganciclovir. For severe cases, we start by intravenous ganciclovir for the initial treatment, and then we continue by valganciclovir. BK virus is a human polyoma virus that was identified in a transplant recipient with an associated nephropathy. Transmission likely occur via respiratory or oral route, and it colonizes the urinary tract as a principal site of latent infection, and replication occurs during states of immunosuppression. It causes tubulointerstitial nephritis and also ureteric stenosis and obstruction. Hemorrhagic and non-hemorrhagic cystitis also may occur. Light microscopy shows intranuclear basophilic viral inclusions without surrounding halo, and immunofluorescent immunohistochemistry positive test using antibodies against BK or against cross-reaction with SCV40. And electron microscopy shows intranuclear viral inclusions. Treatment strategies: there are no specific guidelines for reduction in immunosuppressive therapy after detecting BK viremia, and due to lack of standardized tools, 2-liter reduction may trigger further replication and increased magnitude of viremia, and too much reduction in immunosuppression is a risk factor for the development of T cell as well as B cell mediated organ rejection. Also, too rapid reduction in immunosuppression could result in immune reconstitution syndrome, which is a risk factor for development of organ transplant rejection or worsening viral replication. So, replacement of CNI or antiproliferative agents with mTOR is tried, and the use of mTOR in place of CNI in patients with polyoma virus infection could at times advantageous for faster and more efficacious V clearance in plasma. There are adjunctive therapies may be tried. IVIG, which is an immunomodulatory immunotherapy, has been studied, and these adjunctive therapies, in absence of well-defined clinical studies, continue to remain elusive in their efficacy for the treatment of polyomavirus reactivation syndrome. Conversion from TAC-MMF to TAC-mTOR immunosuppression after kidney pancreas transplantation reduces the incidence of both PK and CMV viremia as shown by these two figures. Epstein-Barr virus infection. It is a member of herpes family with a seroprevalence of about 90%. Asymptomatic low-level viremia occur in about up to 40% within the first year of transplantation. It is the first identified carcinogenic virus, resulting in a magnitude of cancer as Burkitt's lymphoma, Hodgkin lymphoma, immune-suppressed B-cell lymphoma, post-transplant lymphoproliferative disorder, gastric carcinoma, and nasopharyngeal carcinoma. And for the development of post-transplant lymphoproliferative disease, no cutoff level has been defined. Epstein-Barr virus negative post-transplant lymphoproliferative disorder occur in up to 30% of patients with post-transplant lymphoproliferative disease. More likely to be of recipient origin, tends to be monomorphic, occur at sites distant from the allograft, and tends not to respond to reduction immunosuppression. Diagnosed by clinical unexplained fever, mononucleose-like syndrome, gastrointestinal obstruction, perforation, or bleeding, infiltrative disease of the kidney allograft, infiltrative disease of liver or central nervous system. Treatment is by reduction of immunosuppression. If no response to reduction, chemotherapy and anti-CD20 may be tried. For CNS involvement, irradiation may be needed. Influenza viral infections affect post-transplant recipient also, and more serious presentations may occur in immunocompromised patients, including primary viral and secondary bacterial pneumonia, rhabdomyolysis, or encephalitis. For COVID-19, as we know, it binds to angiotensin-converting enzyme 2 receptor located on alveolar cell and intestinal epithelial cells, and incubation is for the average about 4 days, and infection progression dyspnea followed by hospital admission and then ICU and admission and intubation in more serious cases. The lab CBC normal except for lymphopenia. Low platelet count is of poor prognostic sign. Elevated D-dimer is common. COVID-19 does not appear to increase procalcitonin, and COVID does increase CRP. Abnormalities noticed in lab, elevation in D-dimer, CRP, LDH, troponin, ferritin, CPK, and decrease in lymphocyte count. X-ray images, CT of typical findings of ground glass opacities in patients with COVID-19, and for treatment, multiple clinical trials are tried, but now we accepted remdesivir, lopinavir, molnupiravir are recommended for treatment, and for monoclonal antibody therapy may be used if available in moderate patients with more than 3 risk factors, which are age more than 65 years, body mass index more than 35, comorbidities as malignancy and immunosuppression, with risk of progression to severe form, but contraindicated in hypoxic patients. Prognosis, 80% do not get significantly ill. If a patient is hospitalized, 10% will require ICU care, 10% will require intubation, and 2 to 5% will die. And risk factors are age, coronary artery disease, hypertension, diabetes, and COPD. Pneumocystis jirovecii pneumonia, previously known as Carini, is a significant opportunistic pathogen in organ transplantation, and before routine BCP prophylaxis, the overall incidence ranges from 2 to 15%, and risk factors are more intense immune suppression, particularly corticosteroids and depleting antibodies, also pre-existing or co-infection with CMV. Patients present by dyspnea and hypoxemia out of proportion to physical and radiological findings, and in the era of COVID, usually we miss the diagnosis of this pneumocystis pneumonia, as also the CT manifestations of pneumocystis pneumonia also contain ground glass opacities, and that confirmation of the infection is confirmed by demonstration of organism in lung tissue or respiratory secretions, and usually requires induced sputum or bronchoscopy for bed. Treatment by cotrimoxazole minimum for 14 days. Second line, bentamidine, adjunctive high-dose steroid if patient is hypoxic. Prophylaxis also, we give prophylaxis with triamcinolone sulfamethoxazole for 6 up to 12 months post-renal transplantation, and under special cases we continue for life prophylactic treatment. Post-transplant UTI is the most common infection following kidney transplantation and has been reported in 42 to 70% of patients. Prevention by taking prophylactic antibiotic pre-transplant, and also we can give triamcinolone sulfamethoxazole, which also will cover BCB prophylaxis. Broad-spectrum antibiotic prophylaxis administered pre-operative, ensure timely removal of urinary catheter, and don't forget the ureteric stent to be removed 1 month after transplantation. Clinical features may be asymptomatic or irritative urinary tract symptoms as dysuria, frequency nocturia, graft pyelonephritis manifesting as fever, graft tenderness, often systemically unwell, and graft dysfunction. Systemic inflammatory response syndrome and septic shock may occur, and don't forget that UTI is a risk factor for rejection. Diagnosed by urine analysis and midstream urine for culture and sensitivity, and we have to do ultrasound to exclude obstruction as a cause. E. coli is the most common pathogen, but others as Enterococci, Pseudomonas, Klebsiella, Staph, and the Enterobacter may be present. We start treatment by empirical antibiotic, and therapy, of course, should be guided by culture and sensitivity. Avoid nephrotoxic antibiotics. Graft pyelonephritis, we prescribe amoxiclav intravenous for 10 to 14 days, plus gentamicin intravenous. Mr. Chairman, dear colleagues, to conclude, as a result of the masking ability of immunosuppressants, kidney transplant recipients may not present with typical symptoms and signs of infection. A high index of suspicion combined with knowledge of the environmental exposure and potential infections that occur during specific times after transplantation will help transplant practitioners in their evaluation and diagnostic testing. And thank you.